I'm so sorry, I have muted myself, and I would like to welcome all of you once again for yet another stoppage at the Shri Knowledge Academy CPG webinar program. Just before going into today's interesting topic, I would wanted to invite you to concentrate on some of the housekeeping messages throughout this webinar series. As all of you know that today's webinar link will be only available until 9:45 a.m. to join in, and no late attendees will be entertained after 9:45 a.m. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NC-CPD guideline. In case of you have logged off due to power shortage or any other reasons, there's a number that we will be posting on the chat box. Please do note that down and call us through that number to let us know that you have been logged off, and so that we can log you in once again. Thank you very much for strictly adhering for this all the CPD regulation and your kind compliances also. Moving in to today's session, we have a very tiny topic about the interpretation of ECGs and as an overview. Today, our guest lecturer is a fine product from the University of Colombo, Faculty of Medicine, and has finished his foreign training and have been working in Sri Lanka for last 8 years. Dr. Amila Valawatha, a consultant interventional cardiologist from the District General Hospital, Chilao. Sir, thank you very much for joining with us, and previously also you have been very kind and giving us your wisdom. Please do conduct your timely lecture today. Thank you very much, and over to you, sir.
Right. Thank you, Sahan, for that kind words of introduction. So my presentation will be on interpretation of ECG. So we will start with the very basics and proceed. So yeah, so ECG, as we all know, is a graphical illustration of cardiac electric activity. So the cardiac myocytes, when electrically get activated, it produces electric current, and this electric current is graphically illustrated in the ECG. Basically, more the number of cardiac myocytes which are activated, the higher the deflection in the ECG. Also, this electric current is measured using electrodes. So we have two ends, a positive electrode at one end and a negative electrode at the other. So we basically have two electrodes in some situations. Some situations we have one electrode and one composite electrode. Composite electrode is an electrode where multiple electrodes are united together to form one end. That's a composite reference point. And then on the other hand, we have another electrode called the positive electrode. So a combination of two electrodes or two ends produces a lead. We will talk about in details as we go. So what is this cardiac electric activity? So cardiac electric activity is generated when the cell membrane get depolarized. So cell membrane get charged due to movements of ions. As we all know, the depolarization is the charging of the cell membranes, where the inside of the cell becomes positively charged due to inward sodium ion movement. And when the membranes get decharged, that is the charge disappearing, the potassium ions move out of the cell, reducing the positive charging inside. So that's called the repolarization. We have a charging, depolarization, and the decharging or the repolarization. Both these currents produces waveforms in the ECG, right? So when cardiac myocytes get activated, the impulse spread from one cell to another, producing electric current. So that is the basic of the electric activity. Now, if you look at this, this is, as you can see, this is a picture of the heart. We have the sinus node here, and the impulse travel down to the AV node, then through the His bundle and the Purkinje system to the ventricle. So when the atria gets fired, it produces the P wave, that is atrial depolarization. Okay? So then the ventricles get depolarized, that produces the QRS complex. Towards the end, the ventricle get repolarized over producing the T wave. So we have the P wave, the QRS complex, and the T wave. And there are a couple of intervals we talk of from the beginning of the P wave to the beginning of the QRS. We call it the PR interval. Right? This is usually less than 5 small squares. Right? And then we have from the QRS complex beginning to the end of the T wave, we call the QT interval. So these are some of the intervals we'll be talking as we go on. So that is basically the way the heart electric activity gets conducted down. අපි ඊළඟට කතා කරමු මේ electrodes ගැන. There are different kinds of electrodes. So we have 3 limb electrodes. මේ රතු, කහ, කොළ විදිහට denote කරලා තියෙන limb electrodes. So right arm has the red electrode, the left arm the yellow, and the left leg has the green electrodes. Right? So these limb electrodes together produces the limb leads. As we told you, lead එකක් කියලා කියන්නේ electrode දෙකක එකතුවක්. Positive negative electrode දෙකක් එකට unite කරලා ගත්තාම එන unit එකට අපි කියනවා lead එකක් කියලා. මේ එක එක මේ cables වලට අපි කියන්නේ electrodes කියලා. So එක එක leads තියෙනවා මේ තුන එකතු වෙලා limb leads හැදෙනවා. ඊට අමතරව chest electrodes වලින් chest leads හැදෙනවා. electrodes හැදෙන විදිය සහ the leads හැදෙන විදිය අපි ඊළඟට කතා කරමු cardiac axis එක discuss කරනකොට. So this is how these chest leads are placed in the intercostal spaces. We don't have to remember all these things. So those are some of the technical details. So basically, when we interpret an ECG, first we have to follow this order. First, we have to identify, then we have to know the scale of the ECG, that's calibration, what's the rhythm of the patient, then what is the cardiac axis, and then what are the waves, the segments of the ECG, that also we'll have to discuss. So identification of the patient, there are a few things. We need to know the name of the patient, then the date of birth of the patient, the date of the ECG. First, we'll have to check all that. Calibration. So calibration can scale like it. So scale like කියන්නේ මේ electric activity එක millivolt එකක් කොච්චර උසකින් අපි පෙන්නනවාද කියන එකයි මේ strip එක කොච්චර speed එකකින් හරහට travel කරනවද කියන දෙක තමයි scale එක. එහෙම නැත්නම් calibration එකේදී අපි කතා කරන්නේ. So generally standard calibration is 1 millivolt is expressed as 10 millimeters. So 10 millimeters is 2 large boxes. Each large box is 5 millimeters. 2 large boxes is 10 millimeters. So 1 millivolt එකක් 10 millimeters එකකින් මෙන්න මේ වගේ box එකකින් represent කරනවා ECG strip එකේ. So this should be 2 large boxes in the standard calibration. If you want to see the QRS complex is bigger, for example, your patient has a pericardial effusion and the ECG complex are very small, you can't see. In that case, you have to double the calibration to increase the longitudinal height. Right? So the other thing which we talk in the calibration is the paper speed. The paper speed it has been, it's written down in the ECG as 25 millimeters per second. That is the standard horizontal speed. In this small box, you can see it is the width is 2.5 small squares. This is standard calibration. So 25 millimeters per second, this one large square is about 5 millimeters. So per second, so how many large boxes will be traveled per second? So 5. You have to make 25, you have to have 5 large squares. So that is the travel speed of the ECG strip. So per second, if you have 5 large squares, per minute, how many large squares? 5 into 60, that is 300 large squares equals 1 minute of traveling distance. So if you want to calculate the heart rate, you have to imagine is 300 large squares equal 1 minute. So 300 again, තමයි අපි RR interval එකක with එක large squares වලින් හදලා අර 300 වලින් එක divide කරන්න ඕන heart rate එක calculate කරන්න. So this is, you can see the same patient when the standard calibration at 25 millimeters per second, the RR intervals appear closer. It's about 4 large squares. But in the same patient, when you change the setting to 50 millimeters per second, per RR interval, you have about 8 large squares. So if you didn't look at this particular calibration, you might think this patient is bradycardic, uranius, and you will calculate the heart rate wrong. At 50 millimeters per second, we travel 10 large squares. So per minute, it's 600 large squares. So if you want to calculate in this patient, the heart rate, you have to find out, the RR interval is 8 squares. You have to divide by 600 only, you have to divide number 8 get to know the correct heart, because each minute at 50 millimeters per second, we travel about 600 large squares. Whereas in 25 millimeters per second, it's 300 large squares per minute. So to calculate the heart rate, you divide 300 by the RR interval, that is 4 here, to calculate the heart rate. So calibration is, in simple words, it's a scale of the ECG. Next, we'll move on to the cardiac leads. You can actually work out how the leads are formed. So let's start with the limb leads. So this is the limb electrodes. So lead 1 is formed between these 2 electrodes attached to the arms. This is the positive electrode, the yellow one, the left arm. So when an impulse moves horizontally, rightly horizontally, you have a positive deflection in this electrode. So that is the limb lead L1. So that is exactly horizontal here, as you can see. And in this cardiac axis demonstration, you can see it's lead 1 is absolutely horizontal, right? So then we have the next lead between this red ECG, red electrode, and the left leg one. That is lead 2. So you can see it here. That is the lead 2. That is the direction. So lead 2 in this cardiac axis goes down that way, right? Lead 3 is between this left arm and the left leg, where the positive lead is the left leg one. So that direction is somewhere like that, lead 3. So you can see lead 3 comes at that particular direction, right? Then we have AVL, AVF, and AVR. Those are augmented lead, limb leads. So how are they formed? Then AVL කියන එක හැදෙන්නේ මේ L lead එක, left lead එක, positive lead එක විදියට. මේ දෙකෙන් එන common end එකක්. මේ lead එකයි මේ lead එකයි මේ right arm එකයි left leg එක එකතු කරලා හදන මේ විදියට එකතු කරලා හදන මේ common lead එකක් එක composite reference lead එකක් විදියට ගන්න. එතකොට මේකේ average එක වෙන්නේ මේ මැද හරිය. එතකොට මේක එක end එකක් විදියටත් මේ left arm එක එක end එකක් විදියටත් ගන්නවා. එතකොට මේ විදිහේ heart එක හරහා යන මේ direction එකට යන impulse එකක් තමයි ඒකට හරියටම positive impulse එකක් generate වෙන්නේ. එතකොට AVL එකේ direction එක එන්නේ මේ තියෙන මේ දෙක එකතු කරලා එන එකයි මේකයි AVL එක මේ direction එකට යනවා. So you can see AVL has this particular direction, that is about, this is 0, this is minus 30 direction. මේ direction තමයි AVL එක හැදෙන්නේ. ඒ විදිහටම AVR එක හැදෙන්නේ මේ left sided leads දෙක එකතු වෙලා එන මැද reference point එක ඉඳලා right lead එක පැත්තට එන positive deflection එකක් මේ direction එක තමයි AVR එක. So you can see AVR is in this direction. Similarly, AVF is between these 2 leads, a common reference point, and the inferior leads. You can see it's absolutely vertical. කෙලිම downward direction එකට තමයි AVF එක direct වෙන්නේ. එතකොට මේක බැලුවම තේරෙනවා මේක L1, L2, L3. This is AVL, AVR, and AVF. මේකේ horizontal lead එක වෙන්නේ lead 1, inferior lead එක වෙන්නේ AVF. එතකොට අපි cardiac axis එකක් හදනවා නම් අපි axis දෙක විදිහට පාවිච්චි කරන්නේ L1 එකයි හරියටම පල්ලෙහාට තියෙන AVF දෙක පාවිච්චි කරලා තමයි cardiac axis එක අපි calculate කරන්න පාවිච්චි කරන්නේ. Cardiac axis කියලා කියන්නේ QRS complex එකේ average direction එක. Just a little bit about chest lead. Chest leads වලදී මේ V1 to V6 කියලා electrodes 6ක් අපි use කරනවා. මේකෙදි positive electrode එක විදිහට use වෙන්නේ මේක chest lead එක V1 හරි V2 හරි ඒක අවස්ථාවලදී use වෙනවා. ඒකේ reference එහෙම නැත්නම් negative referencing point එක විදියට ගන්න electrode එක හැදෙන්නේ මේ limb leads තුනම එකතු කරලා හදන common lead එකකින්. ඒකට ඒකේ reference point එක වෙන්නේ හරියටම heart එකේ ඇතුළත තියෙන reference point එකක් තමයි අර location තුන average කරාම එන්නේ. එතකොට වැදගත්ම දේ තමයි මේ chest leads වල අපි analyze කරන්නේ heart එකේ inside එකේ තියෙන reference point එකකුයි anterior body surface එකේ තියෙන reference points ටිකකුයි තමයි reference වෙන්නේ. එතකොට ඒකේ plane එක cardiac axis the electric axis එක මේ record වෙන්නේ මේ chest leads වලදී හරියටම horizontal plane එක. දැන් limb leads වල එහෙම නෙමෙයි මේ විදිහට vertical මේ coronal plane එක තමයි cardiac axis එක හදන අපි calculate කරනකොට electric activity එක record වෙන්නේ. Just a little bit of our basics. So to decide what is the cardiac axis, we go by the limb leads. So this is the normal cardiac axis. So you can see from -30 to +90. මෙන්න මේ range එකම අපි කියනවා normal cardiac axis එක කියලා. +90 වලින් exceed කරලා මේ පැත්තට cardiac axis එක ආවොත් අපි ඒකට කියනවා right axis කියලා. මේ -30 වලින් එහා පැත්තට left එකට ගියොත් අපි කියනවා මේකට left axis කියලා. මෙන්න මේ quadrant එකට අපි කියන්නේ extreme axis කියලා. මොකද right එක extreme වුණත් මේ පැත්තට එන්න පුළුවන්, left එක exceed වුණත් extreme වෙලා මේ common quadrant එකට එන්න පුළුවන්. මේක extreme axis මේකදී අපිට differentiate කරන්න බෑ extreme right ද extreme left ද කියලා. So we use an umbrella term extreme axis deviation when we get the cardiac axis in this direction. So we will talk about how to calculate the cardiac axis. As I told you before, we use this horizontal lead, lead 1, and the downward lead AVF to decide cardiac axis. So when we have a positive lead 1, that means the cardiac axis should be within this half somewhere. A patient game AVF එක positive නම් cardiac axis එක මේ half එකේ වෙනවා. එතකොට මේ දෙකම positive නම් වෙන්න පුළුවන් එකම possibility එක මේ මෙන්න මේ quadrant එක ඇතුලේ තියෙන්න ඕන cardiac axis එක, that should be normal axis. But if you L1 is negative and AVF is positive, where should be the direction? If this is negative, that means the QRS axis should be somewhere there. If this is positive, that means it can't be this way. It has to be within this quadrant. So if we have a negative L1 and a positive AVF, that is right axis. So if your patient has a negative AVF and a positive lead 1, that is more likely to fall within this quadrant, right? But in this quadrant, up to -30 is normal. එතකොට මේ L1 positive AVF negative නම් මේ quadrant එකේ තියෙනකොට අපි මේ -30 පැනලාද නැද්ද කියලා බලා ගන්න අපි lead 2 use කරනවා. ඒකට lead 2 minus වෙනවා කියලා කියන්නේ මේ දෙක අතර 90 degree එකක් තියෙන්නේ මේ -32 +60. lead 2 negative කියලා කියන්නේ මේ -30 exceed වෙලා. එතකොට L1 positive AVF negative and L2 negative නම් may -30 exceed වෙලා, we are pretty sure that that is left axis. If L1 is positive, still it could be within the normal axis. So let's look at few examples. So what should be the cardiac axis here? You can see lead 1 is positive. Lead 1 is positive. It should be within this half. And the AVF is also positive. That means it has to be within this quadrant. If AVF and lead 1 both positive, quadrant given, so that is a normal axis. So this patient, what should be the cardiac axis? You can see here, the lead 1 is negative. Lead 1 negative, may half AVF positive. So AVF positive, quadrant so that is, this patient has a right axis deviation. So what should be the cardiac axis here? You can see here the lead 1 is positive. This is positive, so it should be somewhere in this half. And the AVF is negative, so it should be within this quadrant. So ඊට පස්සේ අපි මේ quadrant එක උනහම මේ -30 exceed වෙලාද නැද්ද කියලා බලන්න. We look at lead 2. Lead 2 එක මෙතන negative. Lead 2 negative කියලා කියන්නේ මේකට right angle එකට තියෙන්නේ මේක. මෙන්න මේතනින් එහා පැත්තට ගියාම තමයි lead 2 negative. So that should be a left axis deviation. මේක මොකක්ද? මේකෙදි lead 1 එක negative. Lead 1 negative කියන්නේ මේ half එක ඇතුලේ වෙනවා. AVF එක AVF එකත් negative. AVF එක negative නම් lead 1 negative නම් මෙන්න මේ quadrant එකේ වෙන්න ඕන. So what is this? That is extreme axis deviation. So generally cardiac axis, if cardiac axis shifted to one side, that means that side is hypertrophy. On the other side, infarction of the opposite side also might contribute to movement of the axis towards the opposite direction also. So rule of thumb, heart axis rotates towards the hypertrophy and away from infarction. So let's look at, it's a common scenario. Sometimes we get patients referred to us because the ECG leads are positioned incorrectly and the interpreter become anxious whether this is abnormal or not. So it's important that we know how to pick up incorrect lead placement. So if you look at this ECG, yeah, so if you pick up the ECG lead 1, you can see that we have a positive lead here and a positive P wave. That's a correct lead placement in your patient. So if you look at this is the normal scenario. So sometimes you get a patient referred to you and the patient has a QRS complex which is negatively placed. So in this patient, how do we know whether this is this can happen due to many possibilities. It can happen due to left and right limb bleeds, misplacement. That means the left arm, the lead which should come up in the left arm has been erroneously positioned in the right arm. So that's limb bleed reversal is one possibility for an appearance like this. The other possibility you can consider is a patient with dextrocardia. So example, if your patient has a dextrocardia, the chest, the limb blades will pick up, the electric impulse will travel away from the limb blades, the left sided lead, so the impulse will be negative as here. The other possibility which we can consider is a right ventricular hypertrophy. So if your patient has a right ventricular hypertrophy, again the cardiac axis will be shifted towards that way, so the L1 will give a negative impulse. So how do we differentiate between the three? So the difference is that if you got a limb bleed reversal only, the chest leads will look absolutely normal. So chest leads, if you look at them, V1 to V6, it will be absolutely normally looking. Whereas in dextrocardia, as we move away towards from V1 to V6, you can see the QRS complex getting smaller and smaller, right? So in a patient with dextrocardia, the chest leads will look abnormal and the amplitude of the QRS complex will get smaller and smaller as the leads move away towards V6. And also the P wave will be inverted because the atrial activity also move away from the L1. So that will be an inverted P wave. Whereas in patient with right ventricular hypertrophy, you will have a negative lead 1 because the cardiac axis is shifted this way. But the P wave will be mostly upright because the atria is not affected, is predominantly the ventricular hypertrophy you get. So most predominantly you will get a positive P wave. Also, you will find in the chest lead, it will be abnormal with indices of right ventricular hypertrophy. You can see a positive R wave and a strain pattern in the anterior leads. So that's how we discuss about the cardiac axis. So then the calculation of heart rate, as we said, before we calculate the heart rate, we need to know the calibration correctly, especially the horizontal speed. So that will tell you how many large boxes are there per minute, because you want to find out per minute how many RR intervals falls within that minute period. So if your travel speed of the lead is 25 millimeters per second, that means 300 large boxes per minute. So you want to find out how many RR intervals within that 300 large boxes. So each RR interval in this scenario is about 3 per RR interval, 3 large boxes. So you can see, so there should be, if you divide 300 by 3, you get 100 RR intervals per minute. So the calculation of the heart rate here is about 100. So based on the RR interval width, you can calculate as per the table. So what's the RR interval here? It's about 2. So if your horizontal sweep speed is 25 millimeters per second in this scenario, the heart rate would be 150. When you get a patient with irregular rhythm, how do you calculate the heart rate? So here you can't go by a single RR interval because RR interval varies from a beat to beat. So in this instance, we take about 6 seconds. 6 seconds is how many large boxes? Per second, 5 large boxes. So 6 seconds, we have 30 large boxes. So 6 seconds is 30 large boxes. So 6 seconds, within 6 seconds, we will find out how many RR intervals. So then you get that number and you multiply by 10. So 6 seconds into 10 is 60 seconds, that is 1 minute. So you can calculate the heart rate by finding out 30 large boxes and finding out how many RR intervals fall in within that. And then you multiply that by 10 to find the average heart rate. So the few problems we discussed about artifacts. So here you see 2 ECG rhythm strips. So here you will find an abnormal complex, and here you find another abnormal complex. How do we find here which one is the ectopic and which one is the artifact? How do we find out? So you can clearly see in this ECG, despite getting a different morphological complex here in the middle, you will find that the R waves are spaced at regular intervals. So R waves are marching at regular intervals, independent, without getting any disturb by this abnormal complex falling in between. So that means this represents an artifact. It's not a true ventricular ectopic, because if it's a true ventricular ectopic, the reset will be adjusted and this R interval will be pushed away from it. Because this ventricular impulse would make the ventricle refract, so the next impulse will be a bit delayed, will only happen after recovery from the refractory period. So, but in this instance, you can see the RR interval is not affected. So this is likely represent an artifact and not an ectopic. Whereas in this instance, you can see the RR interval, which should come here, has got delay because this ectopic had made the myocardium refractory, so that the next QRS will be pushed away and the rhythm will be disrupted. So this is a truly a ventricular ectopic, whereas this represents an artifact. So these are some of the things which you get electric interferences. The baseline will be disturbed like this, right? Then let's move on to the cardiac rhythm. So how do we find out the cardiac rhythm? So in normal sinus rhythm, we have a P wave and a QRS complex, and there'll be one-to-one correlation between this one P wave, one QRS complex, one P wave, one QRS complex, like that it will go on. And the PR interval would be constant. So that is sinus rhythm. So this is again a normal sinus rhythm. You can see this instance, although it is sinus, the rate is a little low. This is a bit of sinus bradycardia. So let's move on to ECG strip analysis in patients with tachycardia. So when we get a patient with tachycardia, the first thing we look at is, are the complexes narrower or broad? Is narrow complex tachy or broad complex tachy? That we decide by the QRS width. Normally the QRS width is smaller than 3 small squares. So if it's broader than 3 small squares, we call it broad complex. If it's smaller, it means narrow complex. So narrow complex tachycardia means 2 things. One thing, the conduction system is conducting quite normally. And the next thing is that the impulse is traveling up through the AV node, through the bundle of His in the normal way. So if you get a narrow complex, the impulse is traveling from the up, down, and the AV node and the rest of the conduction is conducting quite briskly. So the next thing, when we have a patient with a narrow complex tachycardia, the next thing we look at is it regular or irregularly irregular? That's the next thing we will be looking at. So if you got an irregularly regular rhythm, most of the time you can see that it would be atrial fibrillation. But there are other rare possibilities for that. You can have this irregular rhythm also in certain situations like atrial flutter with variable conduction. You can have multifocal atrial tachycardia, etc. But I'm sure it's most of the time it's atrial fibrillation. So if your patient has a narrow complex tachycardia and the spacing is regular, so what are the possibilities to consider? So as in this situation, you can see narrow complex and regular tachycardia, heart rate more than 100 per minute. So that means the impulse is traveling down the conduction system, and the conduction system is conducting quite healthily. So in this instance, the impulse could start from the sinus node, as in sinus tachycardia. It could start from abnormal atrial focus, like in atrial tachycardia, or a large re-entry circuit within the atrium, uh, like atrial flutter, or it could start from the AV node, like in a nodal re-entry tachycardia, or else it could start from a re-entry circuits in a patient with abnormal accessory pathway. The WP, normally the atrial impulse travel down to the ventricle only through the AV node, but in certain patients you can have abnormal connection between the atria and the ventricles, like in WPW syndrome. So in that instances, you can have impulse can travel down the normal conduction system and come up through the accessory pathway, forming a re-entry circuits of macro re-entry circuits of AVRTO, atrioventricular reciprocating tachycardia. That also will produce a narrow complex tachycardia. So the narrow complex rhythm means it will start from a higher center. They say node, or the abnormal atrial focus, or it could start from a atrial flutter, like a re-entry rhythm within the atria, or it could due to a abnormal re-entry arrhythmia arising from the AV node, or it should be a AVRTO, atrioventricular reciprocating tachycardia in a patient with accessory pathway. So all that can give rise to regular narrow complex tachycardia. So how do we differentiate? So here we look at few things. Now in a patient with sinus tachycardia, you can see this interval, we call it the PR interval, from the P to the QRS complete, we call the PR interval. Then there's another interval which some of the electrophysiologists, especially cardiac electrophysiologists, they analyze, is the RP interval. RP interval means what is preceding this P wave up to the QRS, we call the RP interval. So in a patient with sinus tachycardia, and also in a patient with atrial tachycardia, abnormal atrial focus, this PR interval is shorter than this and than this RP interval. We call this sinus tachycardia, atrial tachycardia, etc. We call them the long RP tachycardias, right? So that is one entity of these patients with narrow complex tachycardias. So we will go on what is the exact opposite of that we will discuss as we go. So you can see here that we talk, in a patient with sinus tachycardia, get a long RP interval. The PR is shorter, RP is longer. We call it the long RP tachycardia. Whereas in a patient with a, with the arrhythmia which starts from the AV node, the impulse will start here, the impulse will travel down, at the same time will travel up. Sometimes we get situations where the atrial impulse will appear just after the QRS complex, most of the time in a negative way. So in this situation, it is not the normal P wave, because the electric activity starts from the AV nodes, goes up and quickly activating the atria, producing these P waves which are inverted. We call it here the RP interval is pretty short, because the node fires and the impulse travels up, producing a negative deflection. So we call this short RP tachycardia. Sometimes in the nodal tachycardia, the P wave is hidden inside the QRS. So you can't see the P wave at certain times. But certain times you can see it just appearing after the QRS. We call it the short RP tachycardia. It can also appear in a AVRT also. We talked of AVRT. Here, the impulse starting here, coming down and going up the accessory. That also can produce a inverted P wave just after the QRS, as here. It will also be a short RP tachycardia, right? But remember, sometimes you will, most of the time, you will not see a P wave, because P wave will be hidden inside this QRS in a AVNRT or nodal oriented tachycardia. So, but sometimes you may be able to see this after also. That will call the short RP tachycardia. So when you get a narrow complex tachycardia, first see whether it's regular, irregular, irregular. If it's irregular, most of the time it's atrial fibrillation. But remember the possibility. If it's regular, look at the P waves. Are there P wave or not? If the P wave is not there, most of the time it will be a AVNRT because the P wave will be hidden inside this QRS complex because the impulse will start from the node. It will travel up and down at the same time. So the P and the QRS will happen on top of each other, merge with each other. You will not see a separate P wave. So most of the time, the diagnosis will be a AVNR. If you have the P wave visible, then we look at before the QRS complexes, how many P waves are there. If you get multiple P waves and the appearance is sawtooth pattern, you diagnose atrial flutter. If you got multiple P waves, but the pattern is not sawtooth, most of the time it will be atrial tachycardia. But if you get only one P wave per QRS complex, then we look at the RP interval. So the RP interval. If your RP interval is long and the PR is short, in other words, the RP interval is long, most of the time it be a, could be a sinus tachycardia, it could be atrial tachycardia. Those are the main things to consider. But whereas if you see an inverted P wave just after the QRS and it's a inverted, the long RP, the short RP tachycardias, you most of the time it will be either AVRT or even it could be a AVNRT or the nodal vein tachycardia. So let's look at some of the examples. So you can see this patient was analysis, narrow complex tachycardia. Number 2, is it regular or irregular? It's regular. So then we look at, can we see a P wave? Yes, you can see a P wave. Is it only one P wave? Yes, it's a one P wave. So this could be either a sinus tachy or atrial tachy. So you look at the patient's old ECG and compare the shape of the P wave, you will find the shape is abnormal. So most of the time, this will be a atrial tachycardia because the P wave shape morphology is different from the normal situation. And it's also a long RP tachycardia because RP is longer than the PR. So it's a long RP tachycardia. So this patient has a atrial tachycardia. So this is a situation of another patient. First analysis here, narrow complex tachycardia, regular. Do we see a P wave before the QRS? No, we can't see a P wave. Only the QRS is there. We can't see a P wave here. So this is most likely to be AVNRT, node firing, impulse going up and down at the same time. The P wave is hidden inside the QRS and you can't see. So most of the time this will be AVNRT. So what is the diagnosis here? Narrow complex regular tachycardia. You can see some atrial organized activity before, but it has a sawtooth appearance and many P waves preceding the QRS complex with a sawtooth appearance. This is likely to be atrial flutter. So then we look at broad complex tachycardia. So when you have broad complex tachycardia, there are two possibilities. One thing, the impulse probably will be of ventricular origin. In that situation, the ventricular conduction is slow. It's not as fast as normal impulse traveling down the conduction system. Because from one cell to another, the impulse has to travel. The complex will be broad. So most of the time, it will be a rhythm starting from the ventricle, or it could be a ventricular tachycardia. What is the other possibility? It should be the impulse coming down the normal conduction system, but the conduction system is diseased due to a bundle branch block. That also can produce a broad complex tachycardia in a patient who has a SVT, and then the conduction is happening through the disease system. That also can cause a broad complex regular tachycardia. So to differentiate VT from a SVT with bundle branch block, we use several things. So what are the things which will tell you that this is a VT and not a SVT with bundle branch block? The absence of a typical bundle branch block pattern. So we'll discuss about what is the typical bundle branch block pattern in the next slides. But when it doesn't conform to a typical bundle branch block pattern, like in this situation, it's more pointing towards a VT. And the other thing is extreme axis deviation. We talked of cardiac axis. So extreme axis can be northwest axis. So that is, if you look at this ECG, you can see L1 is negative, right? L1 is negative. So the impulse is towards that side, the west. Whereas the inferior lead also negative, AVF is also negative. So it should be the northwest quadrant of the cardiac axis. So that is the extreme axis. That will tell you that this is most likely to be a VT. Other thing is the QRS width. So you can see the QRS width is bigger than 4 small scales here, right? Bigger than 4 small scales here. So that is complex is more than 160 milliseconds. So each small scale is 0.04 seconds or 40 milliseconds. So this is 4 small scales. It's quite broad. So that's most likely to be a VT. And when you have evidence of AV dissociation, also you can say that this is a VT. So what is AV dissociation? So if, in a ventricular rhythm, the ventricle will fire independent from the atrium. So you will have the marching ventricular complexes. And P waves you can't see because the ventricular impulse will, ventricle will be refractory in between these complexes, and the atrial impulse is prevented from tracking down because the ventricle remains refractory to the impulse traveling down. So, but in a certain situations, if there's a period, refractory period is over, sometimes in between occasion, in certain patients, certain ECG, sometimes you might see a narrow complex like this happening in between the QRS complex. So here it's a situation, the refractory period is over, and by accident, the atrial P wave generated electric impulse has traveled down the AV node. When the ventricular myocardium has recovered, then the refractory period is over, it has accidentally come down. So this indicates that his conduction system is normal. So this broad complex rhythm is not due to conduction system. This is due to a VT, because the conduction system in the capture beat indicates that the impulse, when comes down normally, the complex is quite narrow. So this indicates that the conduction system is healthy. Hence, this can't be a SVT with bundle transport. This has to be a VT. The same type of a narrow complex beat, when it falls right on top of the QRS complex, we call that the fusion beat. Fusion is complexes merging on top of each other. So the complex shape of the QRS complex will be different. In this situation, you can see this shape and that shape, and this shape is different because right there, the normally conducting impulse has traveled down, falling right on top of the ventricular complex, producing an abnormally shaped ventricular complex from the previous complexes. That's what we call the fusion beats. So capture beats is complexes, narrow complexes falling in between these ventricular complexes, and the fusion beat is a narrow complex merging on top of a ventricular complex, changing its morphology. So this indicates that the atria and ventricles are firing independently, and in other words, AV dissociation. So that is pointing towards VT. So these are some of the ECGs. You can see this is a patient. Broad complex regular tachycardia likely to be a VT. This is a patient with a fibrillating rhythm. This is most likely to be ventricular fibrillation. So what is this diagnosis? It's like a ribbon-shaped complex, the height changing and the twisting axis. This is a torsades T-point tachycardia. That's in patient with lone QT syndromes, right? So these are some of the ventricular arrhythmias which we didn't discuss in detail. So then we're going to talk a bit about the heart blocks. So you can see this sinus rhythm 1-to-1 P to QRS correlation, but the PR interval is bigger than 5 small scale. This is a first equivalent heart block. So what is this ECG? What do you appreciate here? You can see per QRS there's a P wave, but however, although there's a 1-to-1 correlation in most of the time, you can see the PR interval gets gradually prolonged, ending up with a dropped QRS complex. So this is a patient with a second degree type 1 heart block or the Wenke back block. So this in contrast is a situation where you have per QRS, there are multiple P waves. In this situation, actually, there are 4 P waves, but the PR interval is constant. After 4 P waves, only you get a QR. So this is 4-to-1 block. That's also the P wave and the QRS complex are not completely dissociated. There is some correlation, but the correlation is 4:1. So this is a second degree heart block. Second degree heart blocks subtype is type 2 second degree heart blocks. This is type 1 of the Wenckebach, and that is type 2 second degree heart block. But to be more precise, this is a 4:1. So what's the situation here? Again, the patient is bradycardic. There are P waves marching independent of the QRS. There is no correlation between the P wave and the QRS complex. So this is a complete heart block, or the third degree heart block. So we've already told you that the QRS width, the normal QRS width is less than 3 small squares. That is less than 0.12 seconds. So that is a normal ECG. You can see nicely narrow complex because of the healthy conduction system in this situation, and a normal cardiac axis also. So in a patient with left bundle branch block, you will see this M pattern in the V6, and the QRS is bigger than 3 small squares. At V1, you will see the exact opposite of a W pattern. So this is a patient with a bundle branch block. So you can see here a M pattern in all these lateral leads and a W pattern in the anterior layer. So, and the complex is broader than 3 small squares. So this is a patient with a left bundle branch block. In right bundle branch block, you get a RSR pattern in V1 and a RS pattern in the QRS pattern in V6. So, and the complex is wider than 3 small squares. So this patient with the right bundle branch block, you can see nicely the RSR pattern, and in the RSR also unique, this ear or this second peak is taller than the first peak, right? That's a typical RPV pattern. Complex bigger than the 3 small squares, and the QRS pattern in V6. So this is a patient with the right bundle branch block. So these are some of the ECG abnormalities you will see. This is a patient with a lateral T inversion. These are asymmetrical T inversion. You can see it's not a symmetrical tip. There's a slagging and there's a rapid upstroke. This is a strain pattern and a tall ECG complex. So this indicates left ventricular hypertrophy because the impulse will be more stronger. The current is stronger towards V6, producing tall complexes. So when we add the height of this negative complexes and the height of this positive complex, if the tally is bigger than 7 large squares, we call it left ventricular hypertrophy. Similarly, this is a patient with tall, normally you get a negative complex in V1, but when you get a positive complex with this type of a strain pattern, this implies right ventricular hypertrophy. So this is what we talked before. So we can see this is a LV strain pattern with the thing, but what is the difference in this strain, this T inversion and that T inversion? This is symmetrical and fairly deep T inversion, not necessarily mostly in the lateral, but mostly in the anterior leads. This represents ischemia. You can see the strain pattern and the ischemia, the difference. The strain pattern, it's more lateral, more asymmetrical, whereas the ischemia is more towards the anterior leads, fairly deep, symmetrical T inversions. You can see the shape difference between the ischemia and the strain pattern. So this is acute coronary syndrome, and whereas this is a LV strain pattern in a patient with left ventricular hypertrophy. So what is the abnormality in the patient with coming chest pain? What is the abnormality you see here? You can see there are evidence of ST segment depression. So this indicates ischemia, right? This indicates ischemia. And you can see the AVR is a bit elevated. So this is a patient with acute coronary syndrome, probably having multi-vessel lower left main coronary. This is a large area of ischemia, acute coronary syndrome. So let's move on to talk a bit about, ST elevations, STEMIs. So here you will have ST elevations in a patient who is coming with a symptoms suggestive of STEMI, tightening or burning, diffuse pain, poorly localized in the front of the chest, spreading towards the neck or the jaw or the arms. And you have this type of ST elevation, which is most of the cases convex upwards, ST elevations with often with reciprocal changes in the opposing leads. If you have anterior leads, the inferior lead will have ST depressions, but it doesn't happen in everyone. But most of the times you'll find that also. In a patient with suggestive history, you can diagnose a STEM. Here it's very valuable. I mean, you always look at the patient, not just the ECG alone. So even if you don't have the the typical ECG patterns, sometimes if the history suggests, you have to be very vigilant whether that's a STEMI. We'll look at different causes of ST elevation as we go on to the next slides. So in this patient, what do you see? You can see there are gross ST elevation anterior leads. And if you look at the opposing leads, the inferior lead, there are a bit of ST depressions also. So this is the acute anterior ST elevation myocardial infarction. What is abnormality here? You'll find bit of ST elevation in the inferior leads and little bit of ST depression in the opposing anterior leads also. This patient with the acute inferior ST elevation myocardial. So if your patient comes with chest pain, now you are encountered in a situation where the patient has left bundle branch. How do you know whether that is a STEMI or not? Here we look at something called the Garbosa criteria. There are different points in this criteria. You don't have to by heart the details, but just I'll tell you a few salient things to consider to decide whether it's a STEMI or not. Now in a patient with coming with chest pain has a LBB, there are certain abnormalities here. So this is a patient with coming with chest pain and has a LBB. It's actually not a STEMI. You will find that there are little bit of ST elevation here in leads where the QRS complex is negative. So we call these ST elevation discordant ST elevation. Because we call them discordant because the QRS is down. The ST elevation is in the opposite direction. We call it the discordant ST elevation. So for this discordant ST elevation to be significant, it should be more than 5 millimeters of one large box. It should be more than that. But you can see here it's less, right? So whereas if the patient has properly has a STEMI, like in here with LBB, you will find the ST elevation is more marked. The discordant ST elevation is more marked. It's more than one large box, right? So the discordant ST elevation, if it is to be significant, it should be more than 5 large boxes. Then you can think whether it's a STEMI. So if you look at this lead, the QR is upright, but the STs are not up at all. It's in the opposite direction, right? But by chance, if you have ST elevation in this same direction, we call that the concordant ST elevation. Now, in contrast to the discordant ST elevation, where we need to have 5 small boxes or more than 1 large boxes to be significant, the concordant ST elevation, even 1 millimeter is significant. Look at this patient. Discordant is more than 5. Look at these leads. You will have also the same direction ST elevation. That's called concordant ST elevation. So this is truly a patient with LBB and a STEMI, whereas this is a patient with just LBB. Also, mind you, always interpret not just the ECG, look at the patient's history, how unwell the patient is. LBB with a STEMI patient, they are unwell, they have gastric pain. Most of the time, they'll be hypotensive, heart failure, they'll be quite looking. So look at the patient also, not just the ECG, the character of the pain and the ECG features. If you unite it together and analyze, you'll be able to make a precise diagnosis. So these are some of the other causes of ST elevation. So you can see here, the ST elevation is not convex upwards, it's a concave upwards. Also, there's a slight notch here, slurred notch here. This is actually a patient with a normal variation due to early ventricular repolarization, a benign variant in a patient without having, a coronary issue. So, however, again, look at the patient's history. So if your patient is coming with a central chest pain, you think it's a coronary syndrome, and the ECG is this, don't assume that is a normal variant. But if your patient's history is, a bit bizarre, and you get an ECG like that, you can pretty confidently say, okay, this is a early repolarization, a benign early repolarization. So what is this ECG? You'll find loads of ST elevation in most of the leads, most predominant in the anterior and the lateral leads, right? And look at the territory. So I told you when you get ST elevation and inferior lead, often you get the reciprocal changes in inferior leads. But look at here. This is up in anterior lead, also a bit up in the inferior lead also. So it is beyond The ST elevation is not really fitting onto a typical STEMI pattern. It's more than one vessel territory, involve the inferior, anterior, lateral, and all the kinds of things. And look at the shape also a bit convex up, the concave upwards, right? And also, if you look carefully, there are PR segment depression. PR, this is the normal baseline. That point is the normal baseline. Look at the PR, it's more deeper, downwards than that. So the PR is depressed. ST elevation typically, concave upwards, more than one vessel territory. Patient's history also fitting with a pleuritic chest pain. Most of the time, they would be a patient with acute pericarditis, right? So this is another cause of ST elevation. You will find here bit of ST elevation in the anterior leads. You'll find the shape. There's a partial right bundle branch with the RSR pattern, and the ST elevation also has this unique shape of a curved up ST elevation. This actually is a patient with Brugada syndrome. Another cause for ST elevation. You will find this particular unique morphological appearance. But again, I told you, just don't look at just the ECG, also evaluate with the clinical history of the patient. This is another patient, unique ECG, of a patient coming with chest pain. You will find in this patient, the T waves are pretty taller. T waves are quite hyperactive. And you will find in the inferior is also a bit of ST depressions, right? So this is actually a patient with an evolving STEMI, right? Sometimes you will not get the ST elevation appearing in this ECG evolution. After this thing, sometimes you will find in a few hours there are Q waves forms in the anterior. This is a rare variant of anterior STEMI, where you will not get ST elevation. You will get this unique pattern of hyperacute T waves. Most of the time, is this reciprocal changes also, and then they will, without ST elevation, the patient will start forming Qs. This is a STEMI variant, a rare variant called the T-Winter pattern. This is also totally occluded anterior STEMI equivalent, whereas still you will not see the ST elevation in the anterior. It doesn't happen it's a very small percentage of STEMI comes like this, so you don't have to really worry about it. But just look at the, always I told you, look at the patient history. If the history is suggestive, you get a bit of total T waves like that. Look at the patient's overall ECGs if they have, and then you will be able to see that the T waves have started to peak. Also look at the inferior leads, the reciprocal changes. So if you think a situation like this, always seek to help, get on call the cardiac on-call team to have a look. They might do echocardiogram. They might pick up the anterior wall is hypokinetic, and they might think, okay, if this is STEMI equivalent, and better treat as emergency. So, bit about Q waves. Q waves, we know if a small Q wave can be a normal, non-pathological. If it's less than 1 small square in width, and if it's less than 2 small squares in height, it could be a normal non-pathological Q wave. Whereas if it exceeds, more than 1 small square in width or more than 2 small squares in height or the depth, you can diagnose it as a abnormal or a pathological Q waves. You can see here is fairly deep, steeper Q waves and more broader also. So these are proper Q waves. This is a ECG also of another patient. You can see the P wave and the QRS has merged together. There's a little bit of a slurring here. And this is actually a delta wave in a patient with a WPW syndrome. I conclude my presentation with that. It's not a comprehensive full coverage of ECGs, but we covered the most area, especially the basics. You should be able to now analyze the leads and what are the axes, what is the calibration, what is the rhythm, and etc. based on this presentation.
Thank you very much, sir, for that very comprehensive and enlightening lecture that you have given us today, as well as the last time you have came today and shared your wisdom, knowledge with many of our colleagues. There are a few questions, sir. There are many questions has come through, but a few questions I have chosen. Some of these questions you've already answered throughout your session, but because they are there, that I would like to read some of them, sir. One is that one colleague is asking what is a RSR pattern, and another one has sent a message saying that how important to identify the RSR patterns.
Yeah, usually in a QRS, complex, we get a first downward deflection. We call it the Q wave, right? So in a patient with like, you look at normal ECG, yeah. So 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 this is a normal QRS complex. So QRS means the first negative deflection, we name that as the Q. Then the first upward, the deflection, we call it the R wave. Then the following the R wave, you get a negative deflection, we call it the S wave. So this is the normal QRS, not normal here, the white width is more, but the shape is this we call the QRS complex. So if you get without getting a negative deflection, the first wave is a positive deflection, we call it the R wave. Then the negative one will be called the S wave. And if you get another one, we call it again another RS. So this is the RSR pattern. First deflection is upwards, the next deflection is downwards, and the third deflection is upwards. We call it the RSR pattern. If also the width of this RSR pattern, if it's more than three small scales, we call it the proper bundle branch block or the right bundle branch block in lead one. Looking at lead one. Whereas if you get a patient again, the RSR pattern and the QRS complete less than three small scales, you can call it a partial right branch block. But if it's a typical pattern in V1, you get this upward, downward, and another positive. We call the RSR pattern.
Yes, thank you, sir. And there's another question. There's another question, sir. What are the common findings following CABG, and how long would it take for the ECG changes to become reversed?
Following a CABG.
Yes, sir. No, the question asks, what are the common findings of CABG following probably a myocardial infarction, and how long would it take for the ECG changes to be reversed?
Well, if your myocardium is infarcted in certain territories, you will find that the ECG changes will persist. For example, if your patient had an anterior STEMI, and if there are Q waves in the ECG, I mean, even if you do the bypass, the viable myocardium would recover, but I don't think that the ECG would completely normalize. Whereas if you get a patient with good R waves and there are ischemic T inversion changes, sometimes following revascularization, those would reverse over the next few weeks. But in certain permanent changes wouldn't reverse. But obviously the T waves, ST depressions, those things would reverse over the next few weeks.
Okay, thank you very much, sir. Another question: how to differentiate P wave from the T waves?
It can be a bit challenging, especially in a patient with tachycardia. So you probably will have to look at it carefully. So P waves will be of a different morphology, and you'll be able to see two waves separately in most of the situations. You can have a look at the patient's, prior ECGs and see the shapes of it. And with practice, you should be able to make a, differentiation. So if you look at in this situation, it's quite obvious. You can see a tall T wave and a small P wave separately. So again, you can go by the timing of, you can look at all the leads, look at the PR interval. Is it, in certain leads, you might not see the T wave prominently. In certain leads, you might see more prominently. Again, the P wave also will be the same. So you can look at all the leads and see the PR interval and see the gaps. And then you'll be able to appreciate that this is the P and that is the T. So it's not difficult, but sometimes it can be a little challenging, especially when the patient is with tachycardia.
Yes, understood, sir. Another question asks, is the pathological Q wave after a myocardial infarction permanent, or does it disappear with time?
No, most of the time it will be permanent. Most of the time it will be permanent.
Okay, sir. There are many questions coming through, and but due to the time restrictions, we've decided to stop the Q&A session and move on. But mind you that all the questions that you have sent, we will send to sir in due time in an email, and sir will answer all the questions. And there are many questions came in the pre-assessment also. We will be sending those questions to our distinguished lecturer, and he will reply those things. things via email very soon. So thank you very much, sir, once again for joining with us, joining with Sri, and sharing your knowledge. And we do hope you will join with us in the future also. And many thanks goes to all the participants. There are many participants today has come up and showing that continuous evaluation and continuous knowledge is very important in this session. So I would like to thank everyone for joining in also. To remind you all that just we have the yes, so we do have the link for the e-certificate also posted on the uh, chat box. So please do go through with them, and please do fill the application to have your CPT e-certificate also. Once again, thank you very much for joining with us, and thank you, sir, for giving us your wisdom once again. And we do hope to see you again on next Sunday morning also.